Carcinoma.
Thank you very much, and I'll try and abbreviate a little bit so we can stay on time. My charge today is to answer the question, can liver transplantation cure liver cancer with regard to perihilar cholangiocarcinoma? I do not have any disclosures. And the order of my talk, I want to talk a little bit about transplantation for malignancy, some special considerations. The question about liver transplantation alone for perihilar cholangiocarcinoma, whether or not it has efficacy or should be done. And then liver transplantation after neoadjuvant therapy, reviewing our protocol, results, and several controversies, and then answer the questions. Well, the confounding issue with liver transplantation for malignancy is we just don't have enough organs for everybody that needs them. Everybody is aware of a critical shortage in donor organs, and as transplant surgeons and transplant hepatologists and all of us involved in transplantation, we have to demonstrate appropriate stewardship of these rare resources, including prioritization of our patients awaiting transplantation, and we have a unique responsibility for living donors, particularly for the living donors, that if we were to put them at risk in order to save someone else's life, that we have a reasonable chance for success. And for practical purposes, I always define that as about a 50% 5-year survival, or in the case of most of the indications for which we do transplantation, a 50% 5-year benefit of survival. In transplantation, we also have performance metrics with government and payer oversight, particularly in the US, but also elsewhere in the world. And we have to take into effect the outcome, both for the underlying liver disease, which might progress during the time a patient's awaiting transplantation, or even the progression of malignancy while a patient is awaiting transplantation. As far as liver transplantation alone for cholangiocarcinoma, as you can see from the US registry data published last in 2000, of 207 patients transplanted between 68 and 97, 5-year survival is only about 20%, well below what's considered a reasonable chance for success. Furthermore, there have been at least 3 studies that have demonstrated that liver transplantation alone is fairly ineffective or has results that are equally poor for patients that have incidental cholangiocarcinoma or cholangiocarcinoma detected on the explanted livers. Indeed, those studies include one from the US, another from Canada, and another from the UK. And so we take, as transplant surgeons, we take every effort to make sure that a patient, particularly with primary sclerosing cholangitis, does not have an underlying cholangiocarcinoma. With that in mind, in 1993, my colleagues, Greg Gores, and our colleagues in medical oncology and radiation oncology at Mayo Clinic developed a protocol designed to provide treatment for patients with cholangiocarcinoma arising in the setting of primary sclerosing cholangitis or patients with unresectable de novo cholangiocarcinoma. Many of you are familiar with the protocol. It includes careful patient selection, high-dose neoadjuvant therapy with external beam radiotherapy, and 5-FU chemosensitization, brachytherapy, maintenance chemotherapy with capecitabine while the patients await transplantation, operative staging to exclude any metastases prior to transplantation, and then liver transplantation itself. The rationale for the protocol is with careful patient selection, we felt that we needed to develop very strict inclusion and exclusion criteria because at the time, hilar cholangiocarcinoma was recognized as an absolute contraindication for transplantation. So these criteria were selected specifically to identify those patients that were most likely to respond to neoadjuvant therapy and to survive after transplantation. We employ operative staging to avoid transplantation for patients destined to develop metastases. The radiotherapy and chemotization, it's known that the high-dose therapy is very effective, but can lead to liver failure, but those problems are obviated by transplantation. With liver transplantation, we remove residual disease, almost always accomplished in R0 resection as the hepatic margin is irrelevant. Do treat the underlying PSC when it's present, and avoid, of course, the liver failure due to the high-dose radiotherapy. As far as timing, we do the transplant and the staging operations after the administration of neoadjuvant therapy in order to avoid dissemination during those procedures. Patient eligibility includes strict diagnostic criteria. We rely on either transluminal biopsy or brush cytology, or a malignant appearing stricture and at least one of the following: an elevated CA19-9, biliary ploidy by fluorescent in situ hybridization, or a mass demonstrated with cross-sectional imaging at the site of the stricture. We also require that the tumors arise and are above the cystic duct, but we have done a pancreatiduodenectomy for microscopic involvement of the common bile duct, and we have treated resectable cholangiocarcinoma arising in the setting of PSC, resectable by anatomical criteria, but unresectable due to the presence of PSC. All patients have to have absence of intra and extrahepatic metastases and otherwise be a candidate for transplantation. Exclusion criteria include intrahepatic cholangiocarcinoma, which we consider to be a different disease, uncontrolled infection, prior treatment, a prior attempted resection, intrahepatic metastases, extrahepatic disease, other malignancies, and we've learned to exclude patients that have had a transperitoneal biopsy or fine needle aspiration, including those done by EUS, as seeding almost always ensues. We also exclude patients that have cancers extending 3 centimeters in diameter in a radial fashion perpendicular to the common or to the hepatic duct. As far as the biopsy and FNA of primary cancers, we had 6 patients that we did enter into the protocol that had FNA or biopsies that confirmed cancer. 5 of those 6 patients staged positive with seeding demonstrated at the time of the staging operation, and 1 that did not had a recurrence after transplantation. So we now categorically exclude all patients that have had a transperitoneal biopsy or fine needle aspiration. Our results to date, dating back from 1993 up until this August, include 349 patients that have entered the protocol and been treated with neoadjuvant therapy. 45 patients either died or had progression of disease and fell out of the protocol. A couple were transplanted elsewhere, and 21 were awaiting staging a couple of weeks ago. We've done 277 staging operations, of which 50 or 20% had findings precluding transplantation. Several patients transplanted elsewhere or developed disease progression while awaiting transplantation, and 211 patients underwent liver transplantation, 134 with deceased donors, 76 with living donors, and 1 with a domino familial amyloid donor. Overall survival for the 349 patients with intention to treat analysis was 80%, 51%, and 46% at 1, 5, and 10 years after transplant. 10 years after the start of neoadjuvant therapy, with 74 patients still at risk at 10 years. Of the 211 patients that have undergone transplantation, 1, 5, and 10-year survival is 91%, 69%, and 62%, with 70 patients still at risk for follow-up and disease-free 10 years out after transplantation. As I mentioned, 20% of the patients had findings precluding transplantation, which is usually regional lymph node metastases or peritoneal metastases. We have had 55 recurrences affecting 26% of the patients that had transplantation, which will most often occur in the abdomen, but also distant metastases as well, at a mean of 26 months after transplantation and a median of 18 months after transplantation. We've learned to separate our PSC patients from our de novo cholangiocarcinoma patients. As far as the patients with cholangiocarcinoma arising in PSC, we've had 211 begin neoadjuvant therapy, 171 underwent operative staging, and only 15% or 26 had findings precluding transplantation, and we've done 138 liver transplants. With de novo cholangiocarcinoma, we have treated 138 patients and staged 106. Unlike with PSC, the rate of positive staging is much higher, 28% compared to 15% with PSC, and we've done 73 liver transplants. Overall survival for the patients with PSC after the start of therapy is 78, 60, and 52% at 1, 5, and 10 years after the start of therapy, and 83, 39, and 32% at 1, 5, and 10 years after the start of neoadjuvant therapy. This bottom curve, the de novo cholangiocarcinomas, is the one to compare to the patients that undergo resection. It's an intention to treat analysis, and that overall 5-year survival is not too different than you'd find in patients that undergo an R0 resection. Patient survival after transplantation is 92%, 76, and 70%, 1, 5, and 10 years after transplantation with underlying PSC. There are 50 patients still at risk at 10 years out. And with de novo cholangiocarcinoma, it's 90, 58, and 49% at 10 years, with 21 patients still at risk. The recurrences are much more common in the de novo patients than in the PSC patients, 41 versus 18%. Our experience has been corroborated by 12 other large volume centers in the United States, which reported a combined paper in gastroenterology in 2012. Intention to treat survival was about the same at 53%, and our criteria were justified. That paper does include our experience, however. More recently, our experience has been corroborated by the U.S. Extrahepatic Biliary Malignancy Consortium, which is 10 or 11 centers, but 3 of which do liver transplantation for cholangiocarcinoma, namely Emory University, University of Wisconsin, and Washington University in St. Louis. As you can tell, 5-year intention to treat survival analysis is about the same, and survival after transplantation is about the same as well, and our proportions of de novo to PSC patients was just slightly higher at Mayo Clinic, which explains the higher survival after transplantation. We've learned to predict failure. Protocol dropout is predicted by a high CA19-9 level at the time of presentation, a visible mass, and a high MELD score. Predictors of failure at the time of transplantation include a high CA19-9 that remains high, residual cancer in the explant, and perineural invasion. My charge was to identify whether or not liver transplantation can cure cholangiocarcinoma. So I thought it would be important to look at those number of patients that we have that are alive and disease-free after transplantation. In total, we have 211 patients that have undergone transplantation. 138 are alive. 10 have had recurrence and are alive with recurrence, and 128 patients remain disease-free between 9 days and 26 years after transplantation. As you can see, there are 93 disease-free patients in the PSC group and 35 in the de novo group. Equally important is to look at the deaths after transplantation. What we want to do is to help people live as long as they can with the best quality of life. And those patients that die a long time after transplantation from other causes need to be considered cured as well. We've had a total of 73 deaths, 45 recurrences, which means 28 died with no recurrence, 13 were within a year, which is a perioperative mortality. But 16 of our patients have survived and died more than a year after transplantation, 11 after 3 years, and we've had 10 deaths after 5 years. I think you can consider these patients were cured. Our controversies is whether or not pathological confirmation should be required prior to treatment. We published it in the Journal of American College of Surgery in 2012. This shows cholangiocarcinoma arising in PSC, and as you can see, we do not have pathological confirmation on just slightly less than half of our patients. There was a slightly decreased risk or slightly decreased finding of residual cancer in those without pathological confirmation, but the recurrence rate after transplantation was absolutely identical. Likewise, with cholangiocarcinoma arising de novo, we had slightly more patients without pathological confirmation, but as you know, there are very few malignant appearing non-malignant tumors in the bile duct. The percentages of residual cancer in the explant are about the same, as is the recurrence rates. Finally, we've had controversy on what to do when our common bile duct margin is positive, particularly in the PSC patients, whether or not to do a pancreatoduodenectomy with increased morbidity and mortality after neoadjuvant therapy. We've done that for 10 patients and had 4 recurrences, and we've re-excised 3 patients, all of whom recurred. We now favor going ahead with pancreatoduodenectomy. Our entire experience includes 20 patients, 10 that were planned and 10 that had a margin that was positive. As you can see, morbidity was significant with 3 early deaths, but we had 10 late deaths, 6 due to recurrences, 2 due to other malignancies, and 2 due to other late complications. Our overall survival for this group of 20 patients is 35% at 5 years, with 6 patients still at risk at 7. So the answer is, can liver transplantation cure perihilar cholangiocarcinoma? Liver transplantation alone, rarely, and the results are clearly below the standard of a reasonable chance for success, and the results are equally poor for incidental cholangiocarcinoma. How about for liver transplantation after neoadjuvant therapy? Yes, it can. In a highly selected group of patients where there's strict adherence to protocol, acknowledging that the results are better for cholangiocarcinoma arising in the setting of PSC because we find the tumor earlier than we do for cholangiocarcinoma arising de novo. Thank you very much.
I think we take questions for each since we have different topics on oncology. Yes, please.
IHPBA from Paris. Thanks a lot, Rosen, for this presentation. As you know, in France, we do a study, controlled study, compare resection versus transplantation in resectable perihilar cholangiocarcinoma without PAC. It's interesting to see that we speak about dropout in the group of liver transplantation, but there is also dropout in the group of liver surgery. There is some patients that have not operated because there is a progression. So what is your opinion on this field, meaning liver transplantation in resectable cholangiocarcinoma?
Thank you, Eric, and I congratulate you and the entire French group for conducting that trial, and I'm really looking forward to the results. I have never advocated neoadjuvant therapy and liver transplantation for de novo cholangiocarcinoma that is potentially resectable. I've been involved in a couple of debates, but I've tried to acknowledge that in a consistent fashion. I do think that the results with neoadjuvant therapy and liver transplantation may be slightly better than those that are achievable with resection, but that the difference does not justify the use of either a deceased donor liver or even a living donor liver. That benefit is only 10% or so at most. I think it's important when comparing resection series to transplantation to look at intention to treat. We always show our intention to treat analysis, which for de novos is only 39% 10-year survival, or 39% survival at 5 years. About the same that it is with de novo. And I think as an individual surgeon, when contemplating whether to transplant or resect a patient, you have to look at those patients where you're unsure of the likelihood of achieving an R0 resection, and to multiply the likelihood of an R0 resection, which might be 60 to 80, 85%, times the 5-year survival that you achieve with resection to give you a figure comparable to compare with intention to treat with neoadjuvant therapy.
Okay.
Yes, please.
It's Peter Lodge from the UK. Chuck, could you tell us a little bit about your thoughts about the difficulties of doing live donor transplantation in these patients after all the treatment? And the second thing is that your house?
It seems like my house. That's outside the front door of the Mayo Clinic, and it's my favorite sculpture there. So thanks, Peter. It's always interesting to hear and respond to your comments. And the living donor, initially I thought would be the ideal donor for cholangiocarcinoma, and to use a graft going off the aorta, but that was back in 2000, which is what we do with deceased donor transplantation. We found that size mismatch is a bad thing, and we now use the native common hepatic artery or proper hepatic artery for arterial reconstruction with a living donor transplant. We have a 20% late complication rate, which is usually stenosis. We've had a couple of quick occlusions as well. With the portal vein, we always put in a segment of deceased donor iliac vein as an interposition graft, even if we don't need it, because we also have a 20% incidence of portal vein stenosis, and it's easier to deploy a stent through a transhepatic portal venous stick when that interposition graft is in place, because it's the recipient artery or the recipient portal vein that becomes stenotic. We've also altered our reconstruction with pancreatoduodenectomy, and whenever we've done that, the last 3 or 4 living donor liver transplants that have required a pancreatoduodenectomy, we've used a separate Roux-Y limb for the biliary reconstruction and a conventional pancreatojejunostomy, such that when one leaks, they don't both leak.
Any further question from the floor? Okay, thank you. Thank you very much again.